Hello, my dear future nursing officers. Welcome you all to the Master Nursing classes. So, in this particular today's very important video session, I am discussing such a very important and very high yielding questions and the concept. By holding the one particular very important question, I am trying to solve a nearly 10 to 20 other MCQs and the concept related to that particular question. So my work is clear here to give the very important and high yield and frequently asked questions and the previously asked questions and the very important questions that is much required for your exams. And I want every one of you to take a pen and paper, okay, and write whatever the things I am telling, and wherever I am telling this is important, focus especially on that particular video, okay. And if any one of you are new to the Master Nursing Classes YouTube channel, so please do subscribe to the channel because it is giving you a rank, okay. So very important, all of you stay connected till the end of the video and actively participate in the comment box, whether it may be a hard question I am asking, whether it may be an easy question I am asking. So you have to respond to that and you have to involve in that, otherwise you will be getting sleepy in between the class, right? So I will never make my students to get sleep, okay. I will be very active in the class, so then only my students at least they will be active in the class, right? So I want every one of your active participation in the comment box, and wherever I am telling it is important, especially focus on that one, listen carefully, okay, make your own notes and revise that one. Definitely it will work for you all, right? So let's begin the today's session with this a single and the very powerful motivational line: never give up. If you want to give up, just think why you have started this preparation journey. So to solve your problems, to solve your family problems, and to come out of that dark zone, okay. So if you want to come out of the dark zone and if you want to come out of the negativity which is pulling you, so you have to have the attitude of the never give up. Definitely it will pace one day for you, right? Okay. So here is the small information to you all and who all are especially preparing for the Norcet exams. So just you have to practice like a real exam, okay. So where you will get the 100 questions, which including the 80 questions of the nursing and 20 questions of the non-nursing, which are very important and very high yielding and specially and fully planned and prepared test series. That is the Super 60 Norcet 9 test series. In that one, you will get the real-time experience of the exam, okay, where you will get each section for the 18 minutes, which holding the 20 questions, same as like your Norcet prelims exam, okay. For the mains also you will get the exam papers in that particular course only, that is the Super 60 test series. If you any one of you want, so our app link is there in the description box, you can join from there, right? And if any one of you are preparing for the Norcet 9 and Norcet 10 with a full theory revision of the subject wise, like you will get the medical surgical classes separately, fundamental of nursing classes separately, okay. Subject wise classes, if you require, the master batch 1.0 is there for you all, you can join there, okay. So RM series is for the SGPG and KGMU, which including the special test series prepared for the SGPG and KGMU. Along with that, the non-nursing classes, okay. So where it holds the around 40 marks, right? So that 40 marks we are fixing through the classes, okay. Already recorded classes are added in the RM series. If any one of you want, you can join the SGPG and KGMU RM series also, okay. So let's begin the session here. The first question comes in front of you all like this. So hope everyone joined to the session, and who all are joined to the session, fatafat hit the like button so we can continue the class, right? Who all are joined to the session, so fatafat hit the like button and try to put the correct answer in the comment box. Which of the following drug is absolutely contraindicated in the pregnancy due to the teratogenicity? So option A comes here in front of you all as a paracetamol. Option B is the amoxicillin. Option C is the thalidomide, and option D is the folic acid. Students, it is a very important question, and there was a question asked in your last Norcet 8 regarding the thalidomide, so which is very necessary to study and revise the very important and high yield questions. So after this I will explain all the teratogenic drugs. You can make a list of that one, okay, and in front of that you have to write the what is the teratogenic specific effect which is shown by the particular drug, okay. So yes, many of you are giving the correct answer. So thalidomide is the drug which is absolutely contraindicated in the pregnancy. Okay, so paracetamol is absolutely safe, amoxicillin is safe, folic acid is safe. Okay, so very important, just try to understand the concept here. So question was asked here, which of the following drug is absolutely contraindicated? Means we will never ever give this particular drug in the pregnant lady. Okay, so due to its teratogenic effect. And many of you will ask the question, sir, what is the teratogenic effect? Sir, it is very simple. Whenever the mother will take some drug, that drug will crosses the placenta and which will have the impact on the, that is a bad impact on the fetus. So that is what you call the teratogenicity. Okay, so these are the list of the drugs I will give in the below session. Okay, so you can make a note of that one. So thalidomide is a very dangerous teratogenic drug. Okay, so which will have the specific teratogenic effect like a phocomalia. So we can say the limb reduction defect in the fetus. I will show image also, don't worry. And paracetamol is absolutely safe in the pregnancy. Amoxicillin is safe in the pregnancy. And folic acid is absolute, completely necessary drug. Okay, without folic acid there is no pregnancy. If you are not giving the folic acid in the pregnancy, which will have a dangerous effect. So a must and should give drug. Okay, this is the must and should give in pregnancy. Sir, why because if folic acid is decreased, so which is having a dangerous effect that it will causes the neural tube defect. Okay, so this is the repeated and many time asked, directly asked question. So deficiency of the which vitamin which leads to the neural tube defect? So absolute correct answer is the yes, that is the folic acid. Okay, if the folic acid deficiency is there, which will causes the neural tube defect. Okay, so let me quickly revise all the teratogenic effect of the drug, which this particular table is very important for you all. Okay, so first drug I am discussing here is the isotetranein. Okay, so sir, what drug is this isotetranein? So this isotetranein is the drug, okay, where especially females use this particular drug to reduce the acne. So there are the pimples which were arising on the skin. In order to reduce those pimples, so females will use this particular drug isotetranein. Okay, you have seen some poster roadside, the Rama Bhana for the acne. Okay, so in one shot all your face will be clear. So like this of the advertisements you have seen, the advertisement of the isotetranein. Okay, which is very dangerous drug in the pregnancy, because it will damage us the C and again C. So what are the three C's, sir? One is the craniofacial anomalies it will do. Okay, so it will do the small ears of the baby. Okay, so that is what you call the microtia. Okay, what is the microtia? So ear should be normal like this. Okay, if the ear only like this, okay, so little small ear, so this is what we call as the microtia. Microtia will be seen in the isotetranein teratogenic effect. Okay, other than that, the cardiac defect also it will manifest, and the CNS malformation it will manifest. Sir, I want to remember only one, sir. What I have to remember, sir? Yes, beta, you have to remember one thing, that is the craniofacial anomalies, especially the microtia will be the classically seen in the isotetranein. If you are remaining all triple C, that's well and good. Okay, so the next teratogenic effect is the thalidomide. Okay, so thalidomide, this is the drug. Okay, so this drug will causes the teratogenic effect of the limb defects. Okay, limb defects, so that is the phocomalia. Very important for your exam. And it will also damages the ear and eyes of the fetus. Sir, I want to remember only once. Please remember the phocomalia. This will be your again a very important question for your upcoming Norcet exam. Look at this particular image, beta. Are able to see this baby? Look at the limbs of this baby. This is also reducted. Usually length should be like this. Okay, so usual length should be like this. Okay, so here the limbs are not properly developed. All limbs are reducted here. Okay, the small limbs are there. Okay, so all four limbs you can see. This is what we call as the limb reduction defect, or we call this one as in the phocomalia. Okay, what we call this one as in the, we call this one as in the phocomalia. Very important for your upcoming exam. Okay, so we can also call this one as in the limb reduction defect. Okay, so that is the very important for your exam, right? So the next very important drug what we are having here is the valproic acid. Okay, so valproic acid is the drug where we will give. What is the use of the valproic acid? Yes, sodium valproate or the valproic acid. This drug is given usually to treat the seizures in a non-pregnant lady or in the non-pregnant woman and in the males. If the female is get pregnant, that time we should and must and immediately need to withhold this valproic acid because it is having the severe and dangerous side effect as a neural tube defect. Okay, so and that is especially the spina bifida will happens here. Okay, so very important. One thing we have to remember for the valproic acid is the neural tube defect. Okay, and it will also causes the facial dysmorphism and the developmental delay. Especially one thing you have to remember, that is the neural tube defect. Very important. Remember beta, the deficiency of the folic acid will causes the neural tube defect, and along with that a teratogenic effect of the valproic acid will causes the neural tube defect. Very important, we have to keep in our mind. Okay, so the next one is the phenytoin. Okay, so phenytoin is the drug. Okay, this phenytoin, if the pregnant lady is taking, means it will causes the fetal hydantoin syndrome. This is your Norcet question. This is your last Norcet question. Very important, fetal hydantoin syndrome. Okay, so remember, fetal hydantoin syndrome is due to the phenytoin. Neural tube defect is due to the valproic acid. Limb reduction defect is due to the thalidomide, or the phacomelia is due to the thalidomide. Okay, and the microtia, that is the craniofacial abnormality, small ears, cardiac defect and CNS malformation, isotetraneon. Very important beta. So this phenytoin also very important for your exam. Yes, the next one is the warfarin. Yes, warfarin is the drug used to prevent the clotting of the blood. Okay, so it is on the anticoagulant medicine. Warfarin is the anticoagulant medicine. Okay, so this medication, if we are giving in the first trimester of the pregnancy, that time it will crosses the placenta and it will having the bad impact on the pregnant woman. So that is the reason the warfarin is contraindicated in the first trimester of the pregnancy. Okay, so what are the teratogenic effect it will causes? It will make the teratogenic effect in the fetus as a nasal hypoplasia, means nose will develop. Okay, so nose will develop, but it will not completely develop. Okay, so it will develop like this, small one. Okay, so we can say that is the nasal hypoplasia. Okay, inappropriate and improper, okay, size of the nose will be there, so that is the nasal hypoplasia. We can say we will get in the case of the warfarin toxicity. Okay, not in warfarin toxicity, in the warfarin teratogenic effect. Okay, along with that there will be a stippled epiphysis. The very important thing what we have to remember. Okay, so that is the stippled epiphysis. So what is stippled epiphysis? So you know the bone. Okay, in the bone, so here we have the region called as the epiphysis. Okay, so in this epiphysis you will get the dot calcification. Okay, so that is the dot calcification due to the warfarin teratogenic effect in the fetus or in the baby. So that is what you call as the stippled epiphysis. So very important for your exam. Okay, so very important for your exam. Stippled epiphysis or the improper developed epiphysis seen in the newborn due to the which drug teratogenic effect? So that is due to the warfarin. Okay, so primary question will come as a nasal hypoplasia and stippled hypophysis, also very important, and the CNS damage also warfarin will do. Okay, so the next thing what we have to remember is so that is a methotrexate. Okay, so methotrexate is an anti-folate drug. So this is the anti-folate drug. So we will use this methotrexate as a anti-cancer drug also, and we will use this methotrexate as in the drug used to treat the what we can say the rheumatoid arthritis also. It is actually a drug which works against the folic acid. Okay, so that is the reason I told the folic acid is much necessary and very necessary vitamin during the pregnancy because it is necessary for the proper development of the neural tube. If the folic acid is absent, there is a neural tube defect will be there. But here is the drug which works against the folic acid means can we give in the pregnancy? No, we should not give in the pregnancy because the methotrexate will reduces the folic acid and it will causes the a neural tube defect again. Okay, so along with the cranial defects will also will be seen. Okay, so like encephalocele, okay, and anencephaly, okay, and the spina bifida, okay, many things we will see in due to the this methotrexate because it is on the anti-folate drug. Okay, along with that, it will do the abortion also. Okay, so the next one and the very important one for our exam. So that is AC inhibitors. Okay, so in the AC inhibitors, what are the drugs we will get in the AC inhibitors? Yes, can anyone? All the pills. Okay, all the pills like captopril, enalapril, ramipril, pril. Okay, so all the pills comes under the ACE inhibitors. So this particular AC inhibitor, it will causes the renal agenesis. Means so baby will born, but there is no any kidney inside the newborn. Okay, so without kidney the baby will born. Okay, so there is no kidney means no urine output. No urine output means yes, there is less amniotic fluid because every one of you know that the main source of the amniotic fluid in the woman is the the main source of the amniotic fluid is the urine of the fetus, right? So there is no kidney means no urine. No urine means there's less amount of the amniotic fluid will be there. So the less amount of the amniotic fluid we call as the oligohydramnios. Okay. Yes, if the pregnant lady, if by mistakenly she is taking the ACE inhibitors, there will be a renal agenesis, there will be a oligohydramnios. Along with that, there is the pulmonary hypoplasia means underdeveloped what we can say lungs will be there. Okay. So very important for your exam beta. Yes, renal agenesis, oligohydramnios and the pulmonary hypoplasia. It is the teratogenic effect of the ACE inhibitors. So that is the reason ACE inhibitors will never ever be given during the pregnancy. Okay. So next comes to the tetracycline. Okay. Yes. Next drug is the tetracycline we have here. So this particular tetracycline is an antibiotic we use for treating the many kind of the infections. If we are giving this particular tetracyclines during the pregnancy, it will causes the discoloration of the teeth in the fetus and there is impaired bone growth will be there. So this is also asked question previously. It is very important. Okay, it is very important, right? The next one is the aminoglycosides. So aminoglycosides, here we will get the streptomycin, gentamicin, amikacin. Okay, many kind of the antibiotics. So those are the class of the aminoglycosides. Okay, so this aminoglycosides which is having the teratogenic effect of the ototoxicity. Okay, so many times repeatedly asked question, the side effect of the streptomycin. Side effect of streptomycin. Streptomycin is a drug of the classification of the amikacin. It will do the damage to the 8th cranial nerve. Okay, so which will leads to the hearing loss. Okay, so this question have been asked many time. Okay, so keep in your mind, right? So this is the very important aminoglycoside, especially the ototoxic drugs. Okay, so like gentamicin, amikacin and the streptomycin, right? So the next drug what we have here is the lithium. Okay, so previously asked for question on the lithium. Lithium is the drug where we will use for the treating the psychiatric conditions like a bipolar disorder. It will work as a mood stabilizer. Okay, it will maintain the mood in the stable condition. Okay, so if the pregnant lady is taking the lithium, it will causes the abstinence anomaly. It will causes the abstinence anomaly. So what is the abstinence anomaly? So what happens in the abstinence anomaly? Are you able to see this particular picture here? Yes, look at this particular normal heart. In the normal heart, the tricuspid valve which is located here. Okay, so which is located here, this is the normal position of the tricuspid valve. Okay, so look at the image B here. So here actually the tricuspid valve should come like here and it should be like this. Okay, but it is not like this, it is here. Okay, so look at this one, it is here, means there is a downward displacement of the tricuspid valve. What happens in the abstinence anomaly? Abstinence anomaly, there is a downward displacement. Which valve? That is the tricuspid valve. Okay, So this is what we call as the abstinence anomaly. Okay, very very important. The downward displacement of the tricuspid wall we call as the abstinence anomaly. This abstinence anomaly is a very very important teratogenic effect of the our lithium. Okay, so hope it is clear to every one of you. From this particular chart, whatever the thing I am explaining till here, you may get a one question or two question, or you may get the three questions. Okay, because whatever the thing I have explained here, which is very important, and in the last one Norcet itself, we have got the two questions from here. One is the phacomelia, that is the side effect of the thalidomide, and another one is the fetal hydrogen syndrome, right? So you can expect the many questions from this particular chart. Okay, so I hope every one of you have remembered the golden point chanting of the this particular what we can see, the teratogenic effect of the drug. And here are the some assignment to every one of you. Yes, so assignment, the question number 1 tells that is the tooth discoloration and impairment of the bone growth in fetus seen due to which teratogenic effect. Okay, due to dash drug teratogenic effect. Option question number 1 and question number 2, fetal hydrogen syndrome is due to which drug? Question number 3, phacomelia is due to the teratogenic effect of dash. Okay, so you have to mention the drugs here. So these are the very important 3 questions. Already I have explained this thing because this is a special and expected for the next Norcet. I am giving the assignment and I will wait for your comments at the end of the class. Okay, so at the end of the class you have to mention these particular 3 answers. Okay, so remember, take a screenshot, and at the end of the class I will again remember to every one of you. So don't forget to mention these correct answers in the comment box. Okay, so the next one is here. The question is waiting for you all, and I want everyone to actively participate and give the correct answer for this particular question. Yes. Which of the following infection is not a part of the classical torch group? The very very important question for your upcoming Norcet. Which of the following infection is not a part of the classical torch group? Yes. Option A, the toxoplasmosis. Option B, the rubella. Option C, the herpes simplex virus. And option D, human papilloma virus. So I am waiting for your answer in the comment box. Fatafat do response to the question. Which of the following infection is not a part of the classical torch group? Fatafat, students. Yes. So option is the toxoplasmosis. The T stands here is the toxoplasmosis, and R stands here is the rubella. Yes. The C stands here is the cytomegalovirus, and H stands here is the herpes simplex virus or the human papillomavirus. Which one? Which one? Yes, H stands here as the herpes simplex virus. So HPV, human papillomavirus, which is not a part of our torch group. Okay, so torch group of the infections are the infections which are very dangerous and which are easily crosses the placenta. Okay, and which are easily crosses the placenta and which will easily show the teratogenic effect. So it will causes the like toxoplasmosis, it will cause the congenital toxoplasmosis, rubella, congenital rubella syndrome, herpes simplex virus, so congenital herpes, then the like cytomegalovirus also, herpes simplex virus also. Okay, so in the others also we will get some virus, we will discuss that one here. Okay, so whenever the question will comes in front of you all, so you have to remember by using the torch. Okay, the teratogenic infectious agents. Yes, first thing which should come in your mind whenever the question comes to you regarding the teratogenic infectious agent, that is always apply the torch to the a question which is coming as a teratogenic infectious agents. Okay, remember. So torch infection, which is very very important for you all. T stands here as the toxoplasmosis. Remember beta. T stands here as the toxoplasmosis. O stands here as the others. In the others we will see syphilis, varicella, parvovirus B19 and the Zika virus. Very very important. Okay, and the R stands here as the rubella. C stands here as the cytomegalovirus. H stands here as the herpes simplex virus. So you may get, instead of the rubella, you may get the rabies in the option. So eliminate it. Rabies is not part of the torch. Okay, so rabies will be transmitted by the bite of the dog, okay, not by the touch. Okay, remember, right? The next one is the instead of the herpes simplex virus, you may get the human papilloma virus. So try to eliminate this one. Okay, so this is also not a part of the our TARS profile. Remember, yes, T stands toxoplasmosis, O stands others. Others include the syphilis. Okay, so SVPZ, that is the syphilis, varicella, parvovirus B19, and the Zika virus. And the R stands the rubella, C stands the cytomegalovirus, and the H stands here is the, yes, the herpes simplex virus. Okay, so remember the very important points. Okay, so here is the next question for you all. This is the important question. So which classical triad of the congenital toxoplasmosis, which includes all except, so classical triad of the congenital toxoplasmosis includes all except, option A comes here as the chorioretinitis, option B is the microcephaly, option C is the, yes, hydrocephalus, option D is the intracranial calcification. So what is your correct answer? Drop your answer in the comment box. Yes, it is somewhat difficult level question, but at the end of this class you will be very happy, because I am teaching these particular syndromes with some mnemonics, so it will help you all. Okay, so try to write and practice at least 2, 3, 4, 5, 10 times. Okay, so it will help you all. Okay, if something which is giving a good marks to you, so you can work on that, right? So if you are working on the waste content, that is not like, that is your work, you can do whatever you want. Okay, but I will tell, work on the content which is very high yield. This is the time to work on the high yield content, right? So whatever the thing you want to learn in detail, so that was a thing which have been 6 months back, not now. So not now, right? So now we have to work on the high yield content, focus on the high yield content, fix those questions which will come fix in the exams. Okay, so very important, right? So the classical triad of the congenital toxoplasmosis includes all except, yes, you have to remember the congenital toxoplasmosis with this particular mnemonic, Hari is crying. Okay, so H stands here as the, okay, hydrocephalus, means the head with a completely filled fluid inside the, okay, so cranial cavity, right? So in the ventricles of the brain. So that is what we call the hydrocephalus. Okay, so the next one is the I stands as the intracranial calcification. Okay, and C stands here as the chorioretinitis. Yes, so chorioretinitis means, so the infection and inflammation of the choroid and the retina will be there. Okay, the choroid layer and the retinal layer infection inflammation we are getting, and inside the cranium, so there is calcification of the brain is there. So along with that, there will be hydrocephalus will be there. Okay, yes. So the in the option what we have here, that is the chorioretinitis and hydrocephalus, intracranial calcification. Microcephaly is not a part of the our congenital toxoplasmosis. Okay, so what is the mnemonic for the congenital toxoplasmosis? Yes, that is the government is trying to pay him like asking him to pay the tax. That time Hari is crying. Okay, to pay the tax, Hari is crying. So H here is the, yes, related to hair of the head, means hydrocephalus, and I here is the inside, that is the eye inside the brain, that is the intracranial calcification, and C stands here is the chorioretinitis. Okay, so that is the very important thing you have to remember related to the classical triad of the congenital toxoplasmosis. Okay, so which includes the 3 very important significant classical symptoms. Okay, so what is the cause of the toxoplasmosis? If someone is asking what is the cause to organism for the congenital toxoplasmosis, okay, so that is the Toxoplasma gondii is the very important cause to organism. Okay, so the next, the mode of transmission, if pregnant lady she is exposing to the oocyst, so in the mode of the having the undercooked meat, raw meat she is having, and she is working in the cat filter like cat shelters, okay, where she is exposing to the cat feces, okay, and she is having the contaminated soil or contaminated water which is contaminated with the Toxoplasmosis gondii. Okay, so that is the very important thing we have to remember. Okay, so along with that, so this classical triad, and remember the prevention also. Okay, so mode of transmission, that is if mother is exposing to the particular Toxoplasmosis gondii by the exposing to the contaminated water and the soil, so we have to advise her to not expose to the contaminated water and soil and avoid the raw and uncooked meat. So why? Because the Toxoplasma gondii, it may enter to the having the uncooked and raw meat also, so that is the reason. So we will advise the a pregnant lady to avoid the raw and uncooked meat also. Okay. So and avoid handling the cat litters and wear the gloves while handling the cat feces. Right. And we will advise her to wash the fruits and vegetables before having that one thoroughly, because there may be a contamination and she may ingest the oocyst of the toxoplasma gondii, so that may again land her into the toxoplasmosis infection. If the mother is getting the toxoplasmosis infection, especially in the first trimester, so it will crosses the placenta and it will causes the congenital toxoplasmosis in the fetus. So that is the reason the prevention is better here. Okay, so very important. Remember the cause to organism and the mode of the transmission of the toxoplasmosis. And toxoplasmosis is the teratogenic, and I told the mnemonic to remember the classical triad. Hari is crying to pay the tax. Okay, so tax is the toxoplasmosis, to pay the tax. Hari is the crying. Now H is the hair. Hair is related to head. Head is means there is the big head. Okay, so that is the hydrocephalus. I is inside. Inside means the inside the brain. So there is the intracranial calcification is there. Okay, C is the C means what is that? So that is the chorioretinitis. Okay, very important classical triad of the toxoplasmosis. Okay, so hope it is clear to every one of you. And here is the next question which is waiting for you all, right? Fatapat do response to the question now. The triad of Hutchinson in congenital syphilis includes a very important and previously asked question of your Norcet. Just we have completed the T, that is the toxoplasmosis. Now I am coming to the next one, that is the syphilis. Okay, in the others we will study the syphilis. Other than the syphilis, we will study, yes, congenital varicella, then fatapat syphilis, congenital varicella, along with that, yes, the Zika virus. Then one more very important, fatapat. So I have shown the chart here, right? Syphilis, varicella, Zika virus. Yes, come on, parvovirus B19. Okay, so this all comes under the others. Okay, so just we have completed the toxoplasmosis. Now I am discussing related to the congenital syphilis. So this is the important. This is the important. Okay. Yes, I want your answer in the comment box to this particular question. The triad of the Hutchinson congenital syphilis includes. Yes, option A is the cleft palate, cataract, and the deepness. Option B is the Hutchinson teeth and the saddle noise and hepatosplenomegaly. Option C is the Hutchinson teeth, interstitial keratitis, and the sensory neuronal deepness will be there. Okay, and the option D, Hutchinson teeth, chorioretinitis, and the jaundice. So which one is correct answer? Fatapat do mention in the comment box. Well done, beta. Well done. So Hutchinson teeth will be there, interstitial keratitis will be there, and the sensory neuronal deepness will be there. Okay. So this is the classical triad of the congenital syphilis. So this will definitely, there is highest chance of striking in the upcoming exam also. What is the Hutchinson teeth, sir? In the syphilis, you will get the teeth like this. It will be like a like you have seen the JCB. So there is the front portion of that particular bucket. Okay, so the teeth of the bucket. Okay, so it just look like this. Okay, very dangerous teeth. Okay, so these are called as the Hutchinson teeth. Okay, so here you will see the interstitial keratitis. Okay, so there is a keratitis, infection, inflammation, not in there is inflammation, and there is swelling inside the what we can say cornea of the eye. Okay, so that is the interstitial keratitis, and it will damage the 8th cranial nerve also, and patient will experience the deafness or the sensory neuronal hearing loss. Okay, so HID. Okay, so there is the HID is for the, yes, syphilis. HID is for the syphilis. H stands here as the Hutchinson teeth will be there. I stands here as the interstitial keratitis, and the D stands here as the deafness. Okay, so deafness happens due to the what is the reason for the deafness? Yes, for the deafness, the reason is the damage of the 8th cranial nerve. Okay, so damage of the 8th cranial nerve. Okay, so that is the very important thing what you have to remember here. Okay, so yes, what is the causative organism for the syphilis? Anyone want to answer the causative organism for syphilis? Yes, the answer is in front of you all. That is the Treponema pallidum is the very important causative organism, previously and frequently asked question. Okay, so this is the frequently asked question for you all, right? So this is again the deafness happens due to the damage to the 8th cranial nerve, frequently asked question. Okay, so last time Norcet question, that is the Hutchinson triad or the congenital syphilis triad. So there will be a HID will be there. Okay, so that the Hutchinson teeth will be there, interstitial keratitis will be there, along with that the deepness will be there. Okay, so here the option C goes to the correct answer. Hope this particular thing is clear to every one of you. Okay, here is the next very important question for you all, right? So which of the following feature is not a part of the classical triad of the congenital varicella syndrome? It is a not a part. Okay, so which one is the not a part of the classical triad of the congenital varicella syndrome? So students, while studying the dermatology, I have told you people that dermatoma like distribution of the lesions. So there is the cicatricial skin lesions. Okay, so wherever the nerve root will go, there the rashes will be there. Okay, in the only particular side, especially unilateral. Okay, one side of the body. Okay, so that is the cicatricial skin lesion. Okay, so to remember this particular triad of the congenital varicella syndrome, here we have the mnemonic. Okay, so that is the varicella, means in the varicella, so there is a celebrity cricket league you consider. So in the celebrity cricket league, C stands here as the atrophy of the cortex. Okay, so cortex of the brain is getting atrophy here. Okay, another one more C is the cicatricial skin lesion will be there. Okay, so L stands here as the limb hypoplasia. Okay, so limbs are underdeveloped and not completely incomplete development of the limbs is there. Along with that, there will be a atrophy in the brain. So there is a cortical atrophy is there. So along with that, there will be a cicatricial skin lesions. Okay, so these are the very important triad. Okay, you will get the direct question. So like this only in your exam. Okay, related to the classical triad of the congenital varicella syndrome. In the congenital varicella syndrome, you will get the cicatricial skin lesion. You will get the limb hypoplasia, and also you will get the cortical atrophy. And if the cortex is getting atrophy, cerebral cortex is getting atrophy, means cerebral cortex is getting small, means the head size become small. Okay, so cortical atrophy along with the microcephaly will also be there. Okay, so these are the very important three clinical features of the congenital varicella syndrome. But the sensory neuronal hearing loss we will not get. So in the question also they are asked for not a part of the classical triad of the congenital varicella syndrome. So option C goes to the correct answer here. So sensory neuronal hearing loss, it is not a part of the our congenital varicella syndrome. Okay, so this is goes to the correct answer here. Okay, so hope you have enjoyed this particular mnemonic. Okay, so mnemonic for the congenital varicella syndrome, yes, congenital varicella syndrome, the mnemonic is celebrity cricket league. C stands here as the cicatricial skin lesion. Again, C stands here as the yes cortex, means cerebral cortex atrophy, and the L is the limb hypoplasia. Okay, so that is very clear to every one of you. And here is the next question for you all. Fatapat, do read the question and try to explain, try to give the correct answer in the comment box. Okay, the classical triad of the congenital rubella syndrome. This is your very important question. Okay, this is very important question. You may get this question as it is in your exam. Okay, so classical triad of the congenital rubella syndrome includes option A, microcephaly, option B, microcephaly, hydrocephalus, seizures, option B is cataract, cardiac defect and sensory neuronal deafness. Okay, so option C, rash, anemia, limb deformities, and option D is hepatomegaly, splenomegaly, and the conjunctivitis. So what is the correct answer? Yes, remember the C cube. Remember the C cube in the congenital rubella syndrome. In the congenital rubella syndrome, remember particular this C cube. Okay, one C stands here as the cardiac defect, another C stands here as the cataract, another C stands here as the cochlear defect, or we can say the hearing loss. Okay, sensory neuronal hearing loss, very important. Okay, in the cardiac defect also, which one is the most common cardiac defect we will see? That is the patent ductus arteriosus. Okay, so that is the patent ductus arteriosus. Sir, what is the patent ductus arteriosus? So remember better, look at this particular image. Okay, so this image here, first I will say what is ductus arteriosus, then we will go for the patent ductus arteriosus. Ductus arteriosus is just a connection between the descending part of the aorta and our pulmonary artery. So this is our pulmonary artery and this is the descending part of the aorta. So during the intrauterine life, for the fetal circulation, normally there is a connection between the descending part of the aorta and the pulmonary artery. Okay, so that will disappear after the birth. If it is not getting disappear, it is continuously open only and it is patent only. So we call that one as the disease condition. There is the patent ductus arteriosus or the PDA. Okay, so this PDA means, so this particular ductus arteriosus, that is the connection between the pulmonary artery and the descending aorta, is not getting closed after the birth. So that is what we call the patent ductus arteriosus. This PDA will be seen in the case of the congenital rubella syndrome and congenital cataract. So this images you can get in the exam. Okay, so look at this baby image here. So completely opacity of the lenses happened here. Okay, we can easily see. Okay, for bare eyes. Okay, so some babies which requires the ophthalmic examination. Okay, in the ophthalmic examination we will see some whitish thing inside the eyes. Okay, so you can see here, are able to see the congenital cataract. So this is the congenital cataract, congenital cardiac defect, that is the patent ductus arteriosus. Along with that, there will be a cochlear damage. Okay, so which may leads to the sensory neuronal hearing loss. Okay, so this C cube is very important for your exam purpose. Okay, so that is the, yes, that is the triad for the our congenital rubella syndrome. Okay, so remember the congenital rubella syndrome, there is a cataract will be there, congenital cataract, I have shown the image. Then the cardiac defect will be there, patent ductus arteriosus, and the cochlear damage will be there, that is the sensory neuronal hearing loss. Okay, so very important, these questions you will definitely get in the exam. Okay, so hope it is clear to every one of you. And here is the etiology and transmission of the rubella. So rubella, if pregnant mother, she had rubella infection during the first trimester of the pregnancy, there is 90% or the more than 90% of the chance to get vertically transmitted through the placenta and to get infect to the fetus. Okay, so that is the very important chance. That is the reason the rubella is a dangerous, the most dangerous teratogenic infection is the rubella. The most common one is the cytomegalomy. I will discuss in the next question. Okay, so don't worry. Okay, so what is the cause? Cause is the maternal rubella infection. Okay, if the mother is infected by the rubella during the first trimester. Okay, so during the first trimester of the pregnancy, that will easily, the rubella virus will crosses the placenta. So transplacentally or vertically it will get transmitted. So vertical transmission means mother is get infected and the virus become transmitted through the placenta and it is enter the fetus. Okay, that is what you call as the vertical transmission. Okay, so the risk of the fetal infection is more than 90% if the mother is infected in the first 12 week. Okay, so that is the reason it is very dangerous. Okay, so we will get this blueberry skin rashes. Okay, are you able to see the skin rashes? Blueberry skin rashes here. Okay, so are you able to see this particular skin rashes? So these are called as the blueberry muffin rashes. Okay, so these are called as the blueberry muffin rashes. So why this blueberry muffin rashes happens? So this blueberry muffin rashes happens due to the extradermal. Okay, so in the dermis means in the skin there is the extramedullary hematopoiesis. Actually the hematopoiesis should happens in the medullary cavity of the long bones. Okay, but here if it is not happening in the long bones, it is happening out other than the bone area. Okay, so that is the extramedullary means out of the bone area. In the dermal means in the skin the hematopoiesis is happening. So due to this dermal extramedullary hematopoiesis, there is a blueberry muffin rashes will be seen in case of the congenital rubella syndrome. So we will get the baby like this here. Okay, and also along with that the microcephaly will be there and the hepatosplenomegaly will be there due to the extra medullary hematopoiesis. There is a immature RBC which will overload the spleen and which will makes the spleen big. Okay, so there is a hepatosplenomegaly also we will get here. Okay, so very important thing. I'm not going in such a depth here, so because just I am revising the golden points, so that is the reason I am not going in the depth here. Okay, so just I am giving a point which is necessary for your upcoming exam. Okay, so how we have to prevent? So before the pregnancy, okay, not in the pregnancy, I am telling before the pregnancy we have to give the live attenuated rubella vaccine to the mother. If the rubella antibodies are ready, so then we will advise her to conceive. Okay, so we will not advise a rubella vaccine in the pregnancy because rubella is a live attenuated vaccine, and when we will give the live attenuated vaccine during the pregnancy, yes, we are injecting the virus again, So that virus again it may crosses the placenta, and the vaccine itself it may causes the congenital rubella syndrome. Okay, so that is the reason live attenuated rubella vaccine is not given during in the pregnancy. It is given in a pre-pregnancy condition. Okay, so before the pregnancy. Okay, yes sir. So one lady came to my OPD. You consider one lady came to my OPD and she want to pregnant. Okay, and she don't have the any rubella antibodies in her body. Okay, so we will advise her a rubella vaccine. Okay, so I have advised her the rubella vaccine, and she is asking, sir, when I will get pregnant? So I should educate her, and I must educate her. She should and must maintain at least 3 months gap according to the world guidelines. So this one you people should not remember now. So now you have to remember the new guidelines. She should wait at least 28 days or 1 month to get pregnant. Why? Because just we have given the live attenuated vaccine, that is the rubella vaccine. Okay, so this live attenuated vaccine having the ability and potential to cause the placenta and congenital rubella syndrome. In order to avoid that one, the rubella vaccine and the pregnancy in middle, the gap should be 28 days or the 1 month. So this is the new guidelines. Okay, this is the according to the new guidelines. Remember, very important thing for your exam, right? So this particular rubella vaccine which is contraindicated in the pregnancy or during the pregnancy. Okay, so hope it is clear to every one of you. And here is the next question for you all. Which of the following is the most common congenital viral infection? Which of the following is most common congenital viral infection? So option is the rubella, option B is the cytomegalovirus, option C is the varicella, and option D is the herpes simplex virus. But even this is a question with a, you will get a different answer in the different books. So I have seen a good source, and the source where from examiner will create the questions. So very importantly, so in that particular sources, according to percentage wise, the most common congenital viral infection is the cytomegalovirus. Okay, so this is the most common. Okay, so this is the most common congenital viral infection, and rubella is the most dangerous. Okay, and a very important one, most common during interpartum. Okay, so these are during the like pregnancy only. Okay, so during the pregnancy only the varicella will transmit, cytomegalovirus will transmit, and the rubella will transmit. But during the labor or during the interpartum period, okay, most common one is the herpes simplex virus. Okay, so very important. Consider this point, so it will helpful for you all in the exams to eliminate the option at least. Okay, so knowledge is always good for competitive exam preparing candidates. Okay, so the next one, which of the following is the most common clinical form of the neonatal herpes simplex virus? So most common clinical form of the neonatal herpes simplex virus is that is option A, disseminated disease, option B, skin, eye and mouth disease, option C, CNS disease, option D, yes, asymptomatic carrier state. So what is the most common form of the clinical form of the neonatal herpes simplex virus infection? Yes, that is the SEM disease. Okay, the SEM disease, or we can say the skin, eye and mouth disease. So I told this particular herpes simplex virus, so it will mainly transmit during the birth or during the interpartum period. So it will infect the skin, it will infect the eye, and it will infect the mouth. So we call this one is in the SEM disease. Okay, so we call this one is in the SEM disease. Okay, very importantly. So here are the golden points we have to remember on the herpes simplex virus. Most common transmission happens during the interpartum period. All the viruses which we have studied, that is the rubella, varicella, and others like toxoplasmosis also we have studied, and syphilis we have studied, and other before that we have studied the many virus. So everything which are happening before the pregnancy. Okay, so not during the labor, which is this one, that is the herpes simplex, which may directly transmit and highest chance to transmit during the labor process. Okay, so most common form is the SCM, that is the skin, eye, and mouth disease. Okay, and most severe form, that is the disseminated herpes simplex virus. Okay, so high mortality is there here. Okay, and the most common type of the virus which which will cause the herpes simplex is that is the herpes simplex virus number 2. Okay, we have the HSV1 and HSV2. In this HSV2 is the most common one. Okay, so that's the very important. So just we have to remember in our mind. Okay, so the next question is here in front of you all. So try to read the question and put your correct answer in the comment box. Yes, a child has microcephaly, developmental delay, smooth philtrum. Philtrum is very smooth, and the thin upper lip. The likely diagnosis is, what is your likely diagnosis for this question? A child is there which is having a small head, that is the microcephaly, and developmental delay is there in the child, and the smooth philtrum is there, and the thin upper lip is there. So what is the likely diagnosis? Beta. So these are the classical symptoms which will be seen in case of the fetal alcoholic syndrome. Okay, so that is the reason pregnant mother should never ever have the alcohol. Okay, so when the alcohol, the pregnant lady, if pregnant mother is consuming alcohol, okay, in her baby, there are the 3 very dangerous abnormality will be faced. That is the facial abnormalities of the fetus, and the growth retardation, and the CNS dysfunction. Okay, so one is the facial abnormalities. Okay, another one is CNS abnormalities. Another one is the, yes, very important one, that is the growth retardation. Okay, so growth retardation. So these 3 classically features will be seen in the fetus. So that is what you call as the fetal alcohol syndrome. Okay, so especially in the facial abnormality, we will get the smooth philtrum. Okay, so this particular philtrum is the very smooth. Okay, and a very thin upper lip. Okay, upper lip is the very thin. So if I show the image, you will be very much clear about this one. Okay, so this is a case of the fetal alcohol syndrome. Look at this one, microcephaly, that is a small head will be there. So in the question it was mentioned, yes, it was mentioned microcephaly, and small eye opening will be there. Eye opening will be very small, right? So like this, right? So the next one is the nasal bridge, the low, then the flat mid-face, smooth philtrum, thin upper lip. One thing you notice in this one, nothing is increasing, everything is decreasing. Okay, so if you have the alcohol, so money from the pocket also decreases, head size also decreases, and the eye also becomes small, and the nasal bridge also low, and the face also gets flat, and the philtrum also gets smooth, and upper lip also get thin. So nothing will be thick, large, big, increasing, nothing will be there. When the mother will have alcohol, everything will decreases. Okay, so that is the very important thing we have to keep in the mind to eliminate the option. Okay, so everything is decreasing here. Okay, so hope it is clear to every one of you. And special in the facial sense, especially smooth philtrum, thin upper lip, and the short palpebral fissure also will get here. So this will be a classically seen in a case of the our fetal alcohol syndrome. So this goes to the correct answer. This is not seen in the Down syndrome and congenital cytomegalovirus and congenital toxoplasmosis. So these all things we have studied, and the fetal alcohol syndrome is the very important thing for your exam. So that is the reason alcohol is contraindicated during the pregnancy. Okay, so if the child comes with the microcephaly, small head, and the developmental delay will be there, and the smooth philtrum, and the thin upper lip, so these are the classical pictures we will see in case of the fetal alcohol syndrome. Okay, hope you people understood this particular fetal alcohol syndrome, and it is clear to every one of you. Okay, so the next question comes to you. So this is the very important question. Directly it may strike in your upcoming Norcet. The question is on the Bandl's ring. Okay, Bandl's ring is associated with which of the obstetrical complication? Option A, postpartum hemorrhage. Option B, shoulder dystocia. Option C, obstructed labor. And option D, placenta previa. So what is the correct answer? Yes, Bandl's ring is associated with which of the following obstetric complication? So Bandl's ring is associated with, yes, almost all of you have given the correct answer. That is the obstructed labor. In the obstructed labor, we will get a retracted upper uterine segment and distended lower uterine segment. In between the upper uterine segment and lower uterine segment, are you able to see the image? Okay, so this is the retracted upper uterine segment and this is the distended lower uterine segment. In between this upper uterine segment and lower uterine segment, there is a groove, there is a depression. Are you able to see the depression there? Okay, so this particular depression, we call this one as in the Bandl's ring. What we call this one? This one is in the Bandl's ring. Okay, so this one happens. Okay, so mother is trying to push the baby out. Okay, mother is trying to push the baby out, but in the pelvic cavity, some obstruction is there. Okay, so in the pelvic cavity or in the way of the passage of the fetus, in that particular passageway, some obstruction is there. So that may be a tumor in the pelvic cavity. Okay, so that may be due to the small pelvic cavity, that is the contracted pelvis. Okay, that may be due to the congenital problem in the pelvis, like a rachitic pelvis. Okay, pelvis dysmorphalized with rickets. Okay, and along with that there is the contracted pelvis. Okay, or other than that, there will be a chance of the like male like pelvis in the female like android pelvis. So these kinds of the pelvis which not allow the fetal head to easily go out of the pelvis. Okay, so that time, that is what you call the obstruction in the passageway of the labor. That is the obstructed labor. Okay, that time the mother keeps on, she is contracting, but it is not going. So at the peak of the contract, she will feel the very exhausted, she will feel dehydrated, and she will feel very tired, and her heart rate and respiratory rate will increases. Okay, so that time, along with that, when we will examine the mother abdomen, it will looks like, so this is what you call as the ring. Okay, so that is the Bandl's ring. Okay, so very important, Bandl's ring will be seen in case of the obstructed labor. Okay, so this is the normal shape of the abdomen. Are you able to see the normal shape of the abdomen? So this is the normal shape of the abdomen. Okay, but here there is a look in the Bandl's ring. In the obstructed labor, the Bandl's ring will generates like this. Okay, so this is the very important for your exam purpose. Okay, so along with that, there will be a questions which may arise here as a situation based or the scenario based questions. Okay, so whenever we will examine a mother abdomen, so that time we will get a groove or the depression in between the upper and uterine segment and lower uterine segment. Okay, so that is what we call as the Bandl's ring. Okay, so Bandl's ring we will get on examination, and she is very much tired to push the baby out because there is obstruction. Against the obstruction she is pushing means, so she is completely dehydrated here because of the excessive loss of the fluid as sweating. Okay, along with that she is exhausted. Okay, so mother is dehydrated, exhausted, and the Bandl's ring is there. When you will see the respiratory rate, okay, and heart rates, both are increased. Okay, tachypnea and tachycardia will be there. Okay, so this we will see on examination. Okay, when you will see the fetal heart rate sound or fetal heart sound, so there is the distress will be there, or it may, the obstructed labor may lead to the absent fetal heart sound, so due to the death of the fetus inside the particular uterine segment of the mother. Okay, so when we will do the per vaginal examination, so we will get the bleeding. Okay, so per vaginal bleeding will be there, and dry and hot vagina. Previously asked question. Okay, so whenever we are examining the vaginal cavity of the pregnant lady in the obstructed labor, we are getting a dry and hot vagina, and per vaginal bleeding will be there. Okay, if the follis is there, okay, so hematuria also we will get. Okay, hematuria. Okay, and when we will see the fetal head, okay, so fetal head molding will be there. So what is the molding? Molding means the one fetal head bone will overlap into another one. Okay, so this is the molding. Okay, so molding is the overlapping of the fetal head bones due to there is a obstruction is there. Okay, this is the pelvic cavity and the fetal head is coming, and this pelvic cavity is small means, so it will, like, fetal head will compromise like this. Okay, so one bone will overlap on the another bones, okay, of the fetal head. This is what we call the molding. Okay, and we will get the cephalohematoma or caput succedatum. Okay, caput succedatum or cephalohematoma we will get here. Okay, so These two conditions also we will get here. Okay, caput succedatum and cephalo hematoma also we will get. Okay, so along with that we will get the very important classical symptoms. So that is the there is intracranial hemorrhage also we will experience after the birth when we will do the CT of the brain of the fetus. So that time intracranial hemorrhage may also experience. Okay, so but it is not a per vaginal examination, just we can see as a caput succedatum. Okay, caput succedatum. Okay, so caput succedatum, cephalohematoma, molding, Follis catheter, which will be having the bleeding. So there is the hematuria and per vaginal examination. So there is a bleeding will be there and the dry hot vagina we will get. Okay, so these are the clinical pictures will be manifested by the mother with obstructed labor. Okay, so there is a point here. So there is a important point here. Never ever give the oxytocin in the obstructed labor. Why? Because so I told in the passageway the mother is not able to push out the baby. Okay, in the passageway, so there is a tumor or there is another contraction in the pelvis is there. So baby is not going out. That time you are giving the a drug which increases the contraction of the uterus. That is the oxytocin. So again the more contraction will be there. So and if there is excessive contraction against the obstruction thing, so there may be a chance of rupture of the uterus will be there. Okay, chance of rupture of uterus will be there. So that is the reason never give the oxytocin in the obstructed labor. Why? Because there is a chance of rupture of uterus. Okay, so very important you have to keep in your mind. And the best management in the obstructed labor is, yes, best management in the obstructed labor is, that is whether baby live or baby is dead. So always go for the lower segment cesarean section. That is emergency LSCS should be done during the obstructed labor. Okay, so that is the best management for the obstructed labor. Okay, so what are the causes? So causes of the obstructed labor, so question have been asked from here. Okay, so I told the contracted pelvis. Okay, contracted pelvis. So criteria may ask in your exam regarding the contracted pelvis. Okay, so here the obstetrical conjugate. Okay, obstetrical conjugate diameter is less than 10 centimeter, bispinous or we can say interstitial diameter is less than 8 centimeter, bituberous between the two ischial tuberosity. Okay, so diameter is again less than 8 centimeter. So this is what you call as the contracted pelvis. Okay, and sometimes there is a congenital obstruction in the pelvis due to the congenital contraction in the pelvis will be there. So due to the absence of the ala. So what is the absence of the ala? Are you able to see this particular pelvis here? So this is what you call as the pelvic inlet. Okay, so this is what you call the pelvic inlet, and above this pelvic inlet, this part, so that is the iliac fossa. Okay, so this iliac fossa will be called as the false pelvis, and below this particular inlet or the brim, so this particular area we call as the true pelvis, because this particular above the inlet area which will not directly involved in the labor process, and the area which is below the pelvic inlet or the pelvic brim, so that is what we call the true pelvis, because which is directly involved in the labor process. Okay, so just we have divided that one. Okay, so here we have the what we can say, the iliac fossa. Okay, so attached to the iliac fossa we are having the two butterfly shaped bony growth. So this is what you call as in the ala of the sacrum. Okay, so the sacral ala. Okay, we can see separately. So this is the sacrum. Okay, this is sacral promontory, and this is the right side ala, this is the left side ala. Okay, so right and left side ala. If the one ala is absent, so one side ala is absent, so that is what you call the Nagel's pelvis. If both ala, so both side ala is absent, that is what you call the Robert pelvis. Okay, so the question will be asked in your exam. So this is what you call the ala of the pelvis. Okay, this is the ala of the pelvis. Okay, so one ala is absent, We call that one as the Nagel's pelvis. Okay, so what we call that one as in the, we call this one as in the Nagel's pelvis. Okay, so if both are absent, both means, so there is the both means again which will starts for the robot. Okay, so that is the robot pelvis. So here you can remember both and board. Okay, so robot pelvis means both side all are absent and the one ala is absent means there is the Nagel's pelvis. Okay, so that is the very important. So this ala is absent means this particular what we can say pelvis is completely contraindicated, sorry, contracted. Okay, so that is the reason contracted pelvis we can say, right? So one thing, the contracted pelvis, so that may be a like due to the this particular less diameter of the pelvis, or that may be due to the congenital problem or the absent of the ala in the pelvis, or other than that, so I told there may be a tumor in the passageway of the pelvis. Okay, so there may be a tumor in pelvis. Okay, so other than that, there are many reasons will be there, like a rachitic pelvis. So pelvis which is affected with the rickets. Okay, so that is the rachitic pelvis. Okay, so these are the important causes of the our obstructed labor will be there. And if the baby head is big, so that is the, in case of the hydrocephalus, and in case of the macrocephaly we can say. Okay, so or we can say a big baby also. Okay, so in case of the macrosomic baby also we will get a baby weight is more than 4.5 kg. So this particular baby are having the difficulty to deliver the through the pelvic cavity. So that in that particular area, so we have to go for the cesarean section. Okay, so these are the causes of the our obstructed labor. Very important points to remember here. The one ala is absent, Nagel's pelvis, both ala is absent, robot pelvis. Okay, so the criteria of the contracted pelvis. Okay, so very important. And the best management of the obstructed labor, that is the LSCS, that is the emergency LSCS, and the causes on per vaginal examination what we are getting, and why we should not give the oxytocin, and in the fetal heart sound, there is the distressed or absent fetal heart sound, and on examination Bandl ring, dehydrated, exhausted, and the tachypneic and the tachycardic condition will be there. So this Bandl ring is again important. Okay, so this images, the last time directly this image have been came in your Norcet exam as an image based question. Okay, so remember, very important for you all, right? So the next thing is here in front of us. So the question is here, so try to give your correct answer for this particular question. Which clinical sign is most indicative of the cephalopelvic disproportion during the labor? Yes, the question is very simple. Option A is here in front of you all, a rapid cervical dilation. Option B, there is the descent of the fetal head. Then the option B, descent of the fetal head after the full dilation of the cervix. Option C, lack of the descent of the fetal head despite of the good contractions. Okay, there are the good contraction are there, still the fetal head is not coming down. Okay, so that is the option C is telling. Then comes to the option D, strong urge to push early in the labor. Okay, so better strong urge to push early in the labor, so that will not a classical sign of the our cephalopelvic disproportion. So I am eliminating the option D. Then the rapid cervical dilation will not happen in the cephalopelvic disproportion. Okay, so what are the actual situation I will explain so you can understand. Okay, remember, so this is the normal pelvis. Okay, and here is the normal head size is there. So this head is normal, this pelvis is normal, so this particular head will easily come out from this pelvis. Okay, this will be normal vaginal delivery will happen. Okay, so this will be a causes of the normal vaginal delivery. Okay, so the next thing, remember, so here the normal head is there, head is normal, but the pelvis is small. pelvis is small. So this one we call as in the contracted pelvis. Okay, what we call this one? We call this one as in the contracted pelvis. Okay, and third situation, remember, so this is the normal pelvis. This is the normal pelvis, but here is the big head. Here is the big head. So this particular big head, which is not proportioning with the this particular pelvis. Okay, so here also normal vaginal delivery not possible, and here also normal vaginal delivery not possible, because here the head is normal but pelvis is very small, so head will not come out of the pelvis, so normal vaginal delivery is not possible. Here pelvis is normal but head is not coming out because the head is very much big in this particular pregnancy. So this is what we call as the cephalopelvic disproportion, or we can say in short it is the CPD. Okay, so cephalopelvic disproportion will be there. Okay, hope you have cleared the concept here. Okay, beta. So one more thing you have to remember in this particular pregnancy number 1, here in the particular contracted pelvis, so she is first time pregnant. Okay, so that time we have done the cesarean section because the pelvis is contracted, right? So pelvis is contracted, we have done the LSCS. Okay, so that is the lower segment cesarean section we have done, and we have removed the baby. And second time she is getting pregnant, that time can we do the vaginal like per vaginal delivery? Is this possible? No. In the second time also there is highest chance of the obstructing of the labor will be there due to the small pelvis. Okay, so in second time also same pelvis will be there in the mother. Okay, so pelvis will not change immediately after the labor. So in the first pregnancy also same pelvis, vaginal delivery is not possible, and in the second pregnancy also small pelvis, vaginal delivery is not possible. Again, if she is pregnant third time, that time also vaginal delivery is not possible. So the pelvic contracted pelvis is a state of a repeated cesarean section. Okay, this is the state, or we can say the condition of, recurrent LSCS. Okay, so here we can go for the elective cesarean section. So we know the female pelvis is contracted, so we can plan that one. Okay, so we can go for the elective LSCS. Okay, that is a planned LSCS. Okay, especially we will do at the 38 to 39 week of the gestation. Okay, so very important, we have to keep in our mind, right? So next comes to the cephalopelvic disproportion. So first pregnancy the baby head is big. It doesn't mean in the second pregnancy baby also born with big head, in the third pregnancy also baby will born with big head. No, it is not like this. In the first pregnancy big head is there, means there is not possibility of the vaginal delivery, but in the second pregnancy baby head become small. Okay, the baby head will born with the normal head. Okay, in the second pregnancy baby is born with the normal head, means that time normal head will be there, normal pelvis will be there, so that we can deliver the baby per vaginal. Okay, so here second time and third time no need of the cesarean section. Okay, so that is the reason. So it is not a condition of recurrent LSCS. Okay, recurrent LSCS is not required in the cephalopelvic disproportion, but in the contracted pelvis recurrent cesarean section is necessary. How many times the female is getting pregnant, that many times she have to go for the LSCS. But in the cephalopelvic disproportion, in the next second pregnancy baby is born with normal head, means we can go for the normal vaginal delivery. Okay, so this very important thing we have to keep in our mind here. Okay, so hope you have enjoyed the particular session, right? So we will meet again with the next very important videos and the very important concept for in the upcoming future classes. So all of you have to stay connected and watch the videos till the end. Okay, and don't forget to mention your assignment questions in the particular comment box. Okay, so what are the assignment question you have got here? So question number 1 is, yes, the question from the teratogenic effect of the drug. Don't forget, Okay, assignment question. Tooth discoloration and the impairment of the bone growth in the fetus is seen in due to the which drug teratogenic effect? The question number 1. So your answer should be which drug? Yes, mention in the comment box. Okay. So question number 2. Fetal hydantoin syndrome is happens due to the dash. So question number 3. Phacomelia is a teratogenic effect of dash. So these are the very important 3 questions from the teratogenic effect of the drug, and mention your questions answer in the comment box. Okay, and please do hit the subscribe button and like to the class. Okay, if you like the content. Okay, and if you want the more content, just drop a message in the comment box. I will come with the more than the wonderful classes for you all. Okay, which will definitely help you for your upcoming exams of the Norcet 9.0 and other RRB nursing superintendent exam also, and whatever the CRA exam also, it will help, because the content which is I am giving is a high standard content which will meet all the criteria of the nursing government exams of the central level and the state level. Okay, so thank you for watching the classes till the end, and stay connected, stay motivated, stay positive, be away from the negative peoples. Okay, don't compare yourself with others, and you are preparing means yes, you are in a way of the victory. Okay, so no one can stop you. Keep preparing. Goodbye. Thank you so much for watching the class till the end. Okay, we will meet again in the next class. Thank you so much.